Yeah, I will make a start. Good afternoon, everyone. Thanks for joining the Primary Care Commissioning Committee in the August meeting. James Bullion is away, so I'll be chairing the meeting today. Warm welcome also to James Reeder from Suffolk County Council. We should be having Vivian also joining us maybe shortly, who's standing in for Andrew Hayward. I didn't have any chair's actions to report on. Apologies we've received from Andrew Hayward. Good afternoon, Vivian. Great you can join us.
Thank you. Nice to see you too.
I was just saying we had apologies from Andrew Hayward. You're standing in for him. James Bullion, Bill Borrett, Stephen Course, Tricia Dorsey, Sue Merton, and LMC. I believe that's how far we received it. Is that correct, Sarah?
I believe so, yes.
Thank you. Declarations of interest. We received, or we double-checked offline with James Foster. The register suggests his wife is still working as a partner in Orchard Surgery, but her last data was September 30th last year. So more than 6 months have passed, so the register will be updated, and James has been made aware of it. I just want to ask, in view of today's agenda, is there any one who wants to declare an interest? Rosemary?
Yes, I don't know if it comes off now, Hein. I did send an email. I'm no longer an employee of the Humbleyard practice. I left there on the 28th of July.
Maybe Sarah offline you can provide and make sure Rosemary updates the form that's required so that it's properly recorded as such in the register of interest. But thanks for letting us know, Rosemary.
Okay, thank you.
Good. Then we move to review of the minutes of the meeting. You will have seen comments from LMC. So outside the meeting, Sarah, Sadie, and I will review those comments, making sure they're in line with the discussion that took place. And I'm also conscious that James Bullion did review the minutes, but any grammar and textual updates, of course, will be made, and then any update will be circulated to the committee. But let me take the minutes in entirety. Any comments as to accuracy from anyone? Good, I take it as agreement. We move to the action log, which is on page 22 in the pack. Yeah, 22 in the pack. So let me walk through that. Action 109 was sent outside the meeting, so indeed it can be closed. 113, that's an ongoing discussion, but maybe for completeness, Sadie, the next time we have a regular interface update, maybe we can make sure this point is included and we can close it off in that way. I don't know when the next interface update is, maybe in 2 months' time. We'll do it like that.
That's right.
So we'll leave that in open, but the due date will move to October, I think. 114, that's on the agenda today, so it can be closed. Items 115 and 116, I suggest, Michael Dennis, we include that in your update when we come to your agenda item 12. And then 117 and 118, I think that has now been completed. So there is page numbering in the agenda, and there is a list of committee attendees, for which thanks Sarah. And of course, Sarah, many thanks for the minutes, I should have said. So that's a quick review of the action points, and 2 of them we'll circle back to when we come to the prescribing report. Page 23 has a forward planner. You want to highlight anything there, Sadie? Or is it just for information at the moment?
Yeah, just for information. There's nothing to add. Everything on there is here this month, and obviously members can also see what's coming up in the coming months.
Yeah. Thanks, Sadie. I should have mentioned Mark Burgess will join, but a bit later, so we'll park agenda item 6 for now, and when Mark Burgess has joined, we'll come back to this item, which means we can swiftly move on to the Learning Disability Health Checks update on page 29. And Shepard, I hand over to you.
Thank you. Okay, I'm going to provide an update in terms of progress since the last meeting we had. You would have noticed that we've made some progress in terms of the form of words that we needed to include with LMC colleagues. So we met with LMC and agreed some form of words around the contractual position in terms of responsibilities, where it sits, and clearly it's set out there in terms of the LD targets are commissioner targets, and that will be maintained in the report at all times to just ensure that those tensions are acknowledged in there. I'm really pleased that we have now received the April-May data from NHS England, and you would see down in the report that we are making good progress on that. I'm also really pleased with the progress we've made in terms of meeting with the HOSCE, the councillors, last month. It was really a good meeting, and it was well acknowledged that good work and progress has been made compared to last year. There are some challenges that were set for us in terms of demonstrating how we're going to sustain the progress that we have made, and internal discussions are taking place in terms of sustainability, in terms of long-term thinking around that. It was well acknowledged the impact that additional clinical resources in West Norfolk has made, as well as the work that the peripatetic team has done in Norwich. So that was really a positive meeting. In terms of strengthening the work or the progress that we are making on annual health checks, we've started doing some deep dive meetings with each CCG locality to really get a good understanding of the local plans, the opportunities that sit in there, and the challenges that are inherent in different systems. So far, we've held 2 meetings with Norwich and Great Yarmouth, and it's really good to see that LD annual health checks are being prioritized within localities, but notwithstanding the challenges that localities are facing in terms of sickness, pressures associated with COVID, and the general fatigue in the system. So that is not in isolation to other priorities that are in our system. We also had a good meeting with colleagues from NHSE to review the early data that has come through. It was really positive to observe that as a system, not that we are competitive, but we are now leading within the east of England in terms of the number, the uptake of annual health checks, and also the action plans. So we've seen more people than we've done before and compared to others. So I'm really pleased that we are really in a strong position in terms of annual health checks, and fair challenge around how are we going to continue to sustain the good work that we've started. If you look at, just to draw your attention to the table which shows the activity for April-May period, you can actually see that we have actually completed 256 annual health checks in those 2 months, and our decline rate has now reduced compared to last year. So there are some really positive improvements that we've made. And in that table, obviously, yes, we are leading, and I'm really pleased with that. Just to illustrate and just to break down and draw your attention to each locality, how we are doing. It goes without saying that West Norfolk, I think the additional resources that have been put there have made a huge impact. As you can see, at 8% within 8 weeks. I'm curious about Norwich, because it's one of the areas that we invested heavily last year. And in this case, I think the early data shows that we need to look at what's going on. From our deep dives, there were no major concerns with that, but we would look at Q1, where we are sitting in that space. So we are aware of those. So the next challenges that we have, clearly, well set out, obviously, with HOSC around sustainability, and also by our colleagues, LMC colleagues, around the equity of resources. So the tensions that are associated with the prioritization and the targeted approach that we are taking. So we'll be working with colleagues on that. I'll stop there and take any other questions.
Thanks, Shepard. Just clarification, when you say HOSC, that was Norfolk HOSC, correct?
That is correct, yes.
Yeah. Thanks. We'll open up for questions and comments. Vivian?
Thank you, Chair. I'm just trying to get my video to work. There it is. Yes, thank you. And thank you for having me at the meeting. I know I'm a newbie, so forgive me if you all know things that I don't know, which I couldn't glean from the minutes or the notes. I just wondered what the purpose of the health checks was one part of this question. I'm also surprised to see that the bar is so low to be an improvement, because 256 out of 6,000 seems a very low figure. I mean, it's whether we're criterion referencing or norm referencing. I would have thought criteria is preferable for the sake of the residents. And having worked with learning disabilities clients and staff in the past, I wondered what involvement of voluntary sector, other ways of communicating with people with learning disability there is, because quite often I find the language the NHS uses with people with learning disability is not accessible. And do people understand why they're having this check, and what the purpose of it is? What outcome will it benefit them? Because I don't think people are compliant if they can't see the point. So if you've got any of that, I'd much appreciate it. Thank you.
Thanks, Vivian. Steve, Shepard, sorry, will you want to talk to that?
Yeah, I'm really happy to respond to that. I think if I'm right, there are 3 aspects that you've pointed out there for me. So it's around the purpose of the annual health checks, and also the collaborative working with the voluntary sector organization, and also the numbers, probably what do they mean. So if I start with the purpose, it goes without saying that for many years, people with learning disabilities have been marginalized in the way we have commissioned services. We've got more people with a learning disability that are incarcerated, that are still in hospital, and they're being not receiving the appropriate care that we need. And for primary care, it's very important that these needs are identified at the earliest opportunity, that people with their learning disabilities have their checks, their physical and health checks completed, and action plans, health action plans are developed and communicated through all parts of the system where this population is being cared for. So I hope in terms of the purpose, that answers. It's well set out in the long-term plan in terms of premature death. We know that people with learning disabilities die 20 years younger than ourselves. And our data clearly shows that if you look at it, the pyramid shows that the moment we get to 60, 63, 65, the numbers start dwindling. And having to do the early checks and identify some of the underlying causes in terms of the health needs will help us to change that pattern. What we have identified so far, some of the emerging themes is around dental care, diabetes, long-term conditions, access issues. So clearly the purpose is well set out. In terms of the voluntary sector, I think we are really fortunate in Norfolk and Suffolk. We work closely with a number of organizations that have got a huge interest, and it's really helpful to actually see this cohort of people, how they're integrated into the community. And Open Doors in particular have been really helpful in supporting us to really understand the needs of those communities. They've done a very good survey for us, and they've written a good report for us on engagement, consulting with families, and they've given us some pointers on how people with learning disabilities would like to be engaged. So that's really strong. Then in terms of numbers, I'm not sure whether I would say the numbers are low, because the data only shows the last 8 weeks. So in terms of the last 8 weeks, that is April, May period, 256 people seen. That's a reasonable number, given that this is has to be done over a year period. And some people have already been seen in last year, that is, if you look at February, March. So that information is not being included. And I think I've said that I think across the country, Norfolk and Waveney seems to be leading in terms of numbers in uptake and also in terms of health action plans. But we need to maintain that.
Thanks,
I hope
Shepard.
I've addressed the questions that you have posed there. Thank you.
Thank you.
Thanks, Shepard. Any other question? I think picking up on your point on recognizing the ones that already been seen in previous months. One thing that I think would be helpful for the committee to see, Shepard, is an overview that hopefully shows increasingly a higher percentage has been seen, and then we don't start from zero, but also take into account the ones that have been seen last year, to hopefully see that, say, as close as possible to 100% get seen within 18 months or so. So if it's possible to give that perspective in your future reports, that would be helpful. Thanks very much. Then we move to item 8, severe mental illness health check. I believe Julian has joined us. Hi, Julian. I'll hand over to you. You can assume the report has been read, but grateful if you can pick out the highlights. Thanks.
Yes, of course, and good afternoon, everyone. So just focusing on some of the highlights that have happened over the last month. One of the main things that we did
You're
the
breaking.
HOSC group on the. Sorry, can you hear me now?
You could just, at the beginning it was difficult, but please try and I'll let know if I at least can hear you correctly.
I'll try again, and I hope that's a little bit more clearer.
Yes.
Okay, perfect. So just focusing on some of the highlights of the report. The first main thing I would like to draw attention to was the report that we provided to the HOSC group on the 14th of July around the SMI improvement work and plans for the system working across the new ICS. And the feedback and uptake was actually quite positive. So the committee members from HOSC were satisfied with the plans that we submitted to actually address the uptake of SMI health checks And we also drew particular focus on the quality of the check. So we want to move away from this element of a tick box. So just to hit that annual target, but to actually make it more worthwhile for the patient. So the so what behind the check. So once you have your core checks done, what are we doing to actually address some of those inequalities that lie? Are we offering smoking cessation, quality of life, exercise, etc.? It was acknowledged in the report that only 40% of the checks were completed last year, and there was acknowledgement that there was a real need to improve and strengthen the current delivery plans so that effectively we are targeting those patients who've not had their annual health checks and ensuring no one is missed out. One of the main things that came about from HOSC was the ICB was challenged to put in place a long-term and sustainable plan to improve the current position. And we've had buy-in from, I hope I say this name correctly, Tricia Dorsey, who's the ICB Director of Nursing, has agreed to take on leadership of this piece of work, which is really good. In terms of just performance, focusing on Q1, we're still awaiting the validation of our final performance of checks across Norfolk and Waveney, but I am looking through some of our local intelligence. So this is via CQRS and some of the self-declaration that practices have put forward just to acknowledge how much work they have done. And for Q1, and I will caveat that this needs to be validated by a business intelligence team, it does look like across the system, 734 annual health checks have been completed for SMI in Q1. And one of my main things to do for the next time is to ensure there's some benchmarking. So how does this factor compare to last year? Has it increased or decreased? But I will bring that back to this forum. One of the main things for improvement work is to raise the profile of this work that we're doing across SMI. And I represented and attended the West Locality PCN Director meeting, where effectively I outlined some of the plans that we would like to help localities to improve uptake of these checks. And it has been a very positive outcome. Swaffham and Downham PCN in particular have identified some initiatives that they would like to collaborate and work with us on. And the first meeting to start those plans will be tomorrow. So I buy in that localities and practices are aware that SMI and the uptake of their checks is quite high on their radar. And finally, before I open myself to any questions or feedback, I have linked up with the mental health team today around SMI information resource in the form of a website that will have links to NSFT, primary care, finance and coding. There will be two elements to this website, a patient-focused one, but also a collaboration of colleagues. So across the system, colleagues can tap into this website for any help, but also any support that we would like to share. So that's quite an interesting update for me, and hopefully I'll be able to update you all as soon as those advancements come through. But other than that, that's in summary the SMI report for this month.
Yep. Many thanks, Julian. Open it up for questions or comments for Julian. Stunned everyone into silence, Julian. No, nearly. Vivian.
Hi, and at the risk of putting myself out, just one thing, because it just saves me an email. You did send me the email around the financing question, and I can confirm it was from the mental health budget, but I will respond back to you, but that was just a question. Yeah.
Thanks. In the meantime, Vivian has put an electronic hand up. So Vivian, over to you.
Thank you. I'm going to repeat, I think, what I said previously. I get the idea of the health checks. Obviously, the whole area of mental health services are greatly stretched in Norfolk. So I wondered again what the voluntary sector involvement is, and how you find the patients, because they can be very elusive, and how you explain the rationale and participation. Thank you.
That's a great question. Thank you. So one of the main things that I'm quite proud of in the team that we work with for SMI is our participation with the charity Together. So effectively, GP practices, they have register sizes for SMIs when they can do researches on that system. So effectively, what we found out is there are almost two camps of an SMI patient. The first is that hard to reach complex patient that traditionally will not be compliant with their appointments. And the second is those patients that are used to it and are more likely to engage. So what we've done for the last 6 months is to use Together to effectively contact those hard to reach patients for us, so they have the time, resource, and even more of a closer support that I know some of our practices can't divert for this work. And we've had some really positive uptakes. So I think one of the main things which Waveney, which I could do is next time maybe do a small section on the work that Together has done and maybe show some of those contact rates. So for those hard to reach patients, have there been much difference and improvement? We also collaborate quite closely with Mind, and we also tap into quite a lot of user experts by experience user groups that inform some of our main collaboration work. And I think for me, one of the main things that come through is changing the mindset. So it's not just an annual health check that a patient can have. This is a patient right. So they are entitled to this check, and we are trying to empower them to say, actually, I've not had mine. This is my right to the check for my own stability and mental health well-being. So quite a lot of charity work being done, but I might use next month's report to focus on the work that the voluntary sector is doing, as well as patients.
Yes, could I follow that up, Chair?
Yes.
I just wondered about the community connectors and social prescribing elements of local government, because I know quite often they have people referred to them, and the first problem might well be mental health, but I'm not sure the connectors and the first line responders will know about this piece of work. So I wondered how we communicate that to make sure that all the dots are joined up.
One of the just thinking on my feet with this one, and I might have to take it away, but I can tell you that today we've had the third meeting of an annual health check group as a whole. So this is not just for SMI, it's focusing on LD, diabetes, etc. And social prescribing came up as one of the main things that we would like to focus on, as this is something that there's an opportunity there. So one of the main pieces of work that has come out of that is to do almost a plotting exercise to see exactly what's out and available now, as well as some of the roles and responsibilities. So I know, for example, there was a pharmacist in this group who was quite open on there's a lot of prescribing work that their team could help us to do. So I think at this moment in time, I can't take that away just to give a little bit of meat on that response, but I know social prescribing is what we're looking at.
Thank you.
Thanks, Julian. Any other questions or comments for Julian? No, excellent update, Julian. Many thanks.
Thank you very much.
We move to item 9, Estates Quarterly Update. I believe Paul has joined us. Paul, great update, covers quite a few topics, so maybe you can take them one by one. I assume people have read the pre-read, but pick out the highlights.
Yeah, hi, thanks, Hein. I've seen the paper is read, and I've got Captain Walter from my team here who's worked here as well, who'll pick up some of the points from the paper. A couple of things I just wanted to highlight was Appendix 3 of the document, which shows or attempts to show premises capacity and surplus and deficit across Norfolk and Waveney, which was kind of a request from the last committee. We've just presented capacity as it is at the moment. We've got predictions for the next 15 years, but this shows as it was in June 2022. And it's important to note this is capacity from an estate perspective based upon GMS services only. So this doesn't include any other wraparound services such as the R's roles or any space that primary care would like to host for NHS trusts to come into buildings as well. So some practices would probably query this to say we're showing them it's got capacity when they might say that they don't, and that's because they want to offer additional services above the GMS, the traditional GMS services. So the blue circles are those practices which have got current capacity from an estate perspective, and the white circles are those which we think don't have capacity from an estate perspective. This is a kind of a crude formula. It's not perfect because different buildings of different ages have different size rooms, so you can see more patients per square metre in an older building than you can a newer building. It also doesn't reflect the opening hours of practices. So if you're open longer hours, you can see more patients in the building than if you're only open half the week, as an example. But it does help us use as a kind of a benchmarking tool to help assess estates schemes. I'm just going to pick out some of the white kind of areas to give a flavour of some of the things that we're kind of working on. So I'll start from the west of the county and then work east. So in Kings Lynn, we know we've got the Wave 4B scheme in Kings Lynn, and there's a full business case coming to the committee in the private part of the meeting for the proposed move for St James's Medical Practice. So there'll be potentially 2 new developments in Kings Lynn there. Moving kind of west to South Norfolk, we've got the Wave 4B proposal in Thetford. Last time we talked about Attleborough in not a great deal, and I said that we'd hope to have a further update this month, which I don't have. Have to meet with the practice manager on the 15th of July and then share some subsequent information. But we're waiting to get feedback from the practice there on terms of how they then want to take that forward. Once we've got that, we'll then be able to share some more information with the committee. Moving towards Norwich, Norwich is, from this scale, it's hard to see where the variances are. It's to the south of Norwich. We know there's existing problems with the Humble Yard surgery, which is kind of hidden in this map due to the scale. But we're working with the practice there for a potential new build site, which are in the early stages of the scheme development there. To the north of Norwich, we've got schemes in various stages of development again at Drayton and at Taverham. Moving around the NDR, we've got the Rackheath and the North Norwich schemes as part of the Wave 4B. Moving further east, we've got scheme in the early stages of development at Lowestoft at Bridge Road Surgery, which would to use Section 106 arrangement there at Woods Meadow for land for a new build surgery, and potentially there's some access to some SIL funding to help fund the potentially the revenue or the capital costs of the builds there. Where we've got kind of the larger gaps, so Beccles is a kind of one of the larger problems, and then I'd say North Balsham is probably our next largest one, especially considering growth over the next 15 years. We kind of look to the PCN estate strategies to address those. It's not up to the ICB to put in a solution for those schemes, and we'll be looking for the PCN to put forward their ideas, which kind of leads into CAF, and hopefully give us a bit of an update on or will give us an update on the PCN toolkit, please, CAF.
Yes, of course. Hi everyone, I'm Catherine Walter. If you don't know me, I work with Paul on primary care estates. So as Paul said, we wanted to draw your attention particularly to the section in our quarterly update paper, which is National Policy Development and Estate Strategies, and add a bit more detail from discussions that have happened after the paper was submitted. So if I just go back to kind of like the headlines on this, NHS England have commissioned a programme of support. This is a national programme, not just Norfolk and Waveney, to PCNs to help them use the PCN Service and Estates Toolkit to develop clinical and estate strategies. So what that means is that PCNs are going to be invited to a launch event, followed by clinical and estates workshops, which will develop plans and priorities around clinical and estate strategies. And we expect this to kick off in Norfolk and Waveney in September, so next month. So those are the kind of the headlines. So a bit more detail behind it, and obviously we can answer any questions you've got. So to recap, for those of you who've already heard of the toolkit, or if you don't know about the toolkit, it's a national development. It's been knocking about for a couple of years now. It was, well-ish. It was launched sort of last November with a bit more formally by NHS England. And it is national. It's development by Community Health Partnerships, shortened to CHP. If you don't know who they are, they're a company owned by the Secretary of State for Health and Social Care, and they facilitate public-private partnerships around estate. They took on a lot of the head tenancies when PCTs were dissolved. So they're a very estates-based type NHS organisation. So CHP and the National Association of Primary Care developed the toolkit. What it looks like is a set of PowerPoint slides. that walk through the process, and that is then supplemented by a bunch of PDF guidance documents. So that is what the toolkit is. For those of you who recall us talking before about primary care data gathering and that national programme where I know the practice managers present will remember being asked to look at spreadsheets and spreadsheets of data about premises, that national drive to get primary care estate data kind of improved, that data forms part of this toolkit, so it kind of joins up in that sense. The focus, though, is very much on clinical strategies being needed to inform estate strategies. So while we were talking a lot about the estates bit of the toolkit, it's the service and estates bit of the toolkit that NHS England and CHP have really been kind of majoring on. So the support to PCNs will be delivered via CHP, but alongside some other organisations. So health integration partners, who I had heard of, I was racking my brains as to what they'd done in Norfolk and Waveney, but I had heard of them. They'll be delivering support on the clinical strategy development. Then there'll be another organisation who delivers support on the estate side. We don't know who that is yet. So the programme of support, all being well, will start, as I say, in September with a virtual launch event. And CHP then want to follow up with groups of PCNs to start looking at the clinical strategies. The estate strategies then follow on. We're waiting to hear from CHP about the support for Norfolk and Waveney. NHS England had proposed only covering 13 of our PCNs, and they based that on national and local indices of deprivation. So they were focusing on areas with high deprivation. But we pushed back, and we know that other primary care estates teams in the region have pushed back as well, because we think all PCNs should receive the support. We think that's only fair. CHP, when I spoke to them last week, were confident that the budget they've got for Norfolk and Waveney will stretch to cover all PCNs, but it might mean that the 4 PCNs, which weren't part of the 13 they originally proposed to support, might get a lighter touch support. But once we know what that means and what it looks like, we'll assess again. So once we're clear on what's happening, who's doing what, we're together with CHP, and we'll get the launch event set up, get some comms out, and we'll talk through the groups of PCNs that they're going to work with. It does feel a bit like a developing programme, so we're not in any way behind the curve. In the region, Cambridge and Peterborough started with their launch event last Monday, and they're the ones that are furthest ahead, so we're not sort of behind. And I think we said in our quarterly update, the idea is that all these strategies will be written and done by next March, which seems to me like quite a tall order. But I think that probably sums it up now, Paul, unless I've missed anything. It's a kind of just wanted to give you the heads up, and we'll keep you posted, really.
Yeah, the only thing I'd add to that is in terms of the funding that's available, NHS England have confirmed that if there is slippage to March 2023, then it's not a problem for that funding to be carried over into 23-24. That funding will all sit with NHS England. None of it will hit the ICB or none of it will reach the practices directly. It's all funded by NHS England directly. So that's all we kind of wanted to pull out of the paper, but happy to take any questions on any parts of the paper.
Thanks, Paul and Catherine. Open it to questions and comments from anyone. Vivian, and then Hilary.
Sorry, I'm just trying to get my screen up. Don't worry about it. Yes, I'm sorry I'm getting my money's worth, as it's the only meeting I'm attending. But I just wondered what the patient involvement was in procurement, because clearly any shop, for example, that thinks about its customers would think about disabled access and the use it's going to be put, and the comfort and other things that the users of the service would need. So I just wondered where the patient voice is in estates. Thank you.
Yeah, no, that's fine. So depends on the scheme and what the level and size of the scheme is. So if we look at a new build facility and a potential relocation, then we have to do kind of a consultation with relating to that. If there's kind of an extension to an existing premises, we would normally expect kind of the patient participating groups get involved and feed into that. For the Wave 4B schemes, we do have active patient engage or patient representation on all of those schemes. A good example is the Raki scheme. We've got a strong patient participation group there, and do apply quite a bit of pressure to us for that scheme, which is a good thing.
Okay, Hilary.
Thanks, Hein. This question really probably for Catherine or possibly Paul. The funding we're talking about through NHS England to support the development of the clinical strategy and the estate strategy, is that just to develop the strategy? So I suppose my thinking is, what happens if you have every PCN comes back to you and says, we've got this strategy in order to provide it, we need X, Y, and Z. Where does the money come from for that building or that work?
That's a good challenge, and that's the challenge that we've expressed back to NHS England in terms of, it's great to have a strategy, but if our revenue and capital allocations don't adjust, then how are we going to deliver those strategies? At the moment, there is no planned increase for capital for primary care, so we can't. The honest answer at this point, we don't have an answer for that.
So hopefully you don't mind me just asking a follow-on question, Hein. So how can they develop a strategy when they don't have any? You could have a wish list, couldn't you, if we want all sorts of things, which would be fabulous for patients, fabulous for practices, but if there is no idea of any funding or any financial system to support this, how does that work? I'm not being critical of you. It just seems a very odd situation to be in.
I think we're struggling with that query, Hilary, and we're not alone. We know every ICB is, as I said, in the region have said the same thing back to NHS England. So we need to go through that programme and see what that churns out. So we don't know what the scale of what's going to be asked for. We know that NHS England are going to be pushing for better utilisation of assets. I think if I spoke to any practice, they'd tell me that they're sweating their asset as high as they can at the moment. So I don't think that's going to create a great deal, but we might be wrong. Catherine, sorry if I interrupted you there. You were going to come in.
Not at all, Hilary. I was going to say, in my more optimistic moments, I think this might be the means for NHS England to begin to assess what the scale of the ask is across primary care estate. So it may be that they're wanting to know what the priorities are to be able to then determine what they need to think about nationally in terms of capital for primary care. That is in my more optimistic moments. I do also think there's potentially, as Paul has just alluded to, there is potentially this kind of wish to look across estate and see where it could be better utilised and see how much that solves the problem. So I do wonder whether they're looking at it to answer those kind of questions themselves. But it is, when I've been on webinars nationally, this is the conversation that we have, is that how can you expect PCNs to engage with this when there is no funding coming out the other end, as it were? So it's a very relevant challenge, and it is one that we've picked up a lot, but we don't get a very clear answer to it, I'm afraid.
And build on that, assuming you've engaged with all 17 PCNs, is there support to engage with this exercise, or is it sort of sitting on the fence? What do you gauge?
As yet, we haven't really done any comms on the programme to any of the PCNs, because the programme's been a changing beast up until the last few weeks, and we didn't want to go out with something for that to change, which has happened happened in other regions.
Yeah.
There's not really much of a choice. The direction from NHS England that you need to do this, and the funding is there to do it. So we don't know what level of buy-in is going to be yet from those PCNs, but we'll have a better view of appetite following the launch events in the coming weeks.
Yeah. Good. Any other questions or comments? No. Thank you very much, Paul and Catherine, for the update. It takes us to item 10, the digital quarterly update. Or are you reaching out to Sarah? Sarah?
Yes, I have tried to prompt her. Unfortunately, she's not responding at the moment.
Okay, and no worries if you, I'll see if she joins, but we'll move for now on to the CQC reports. That's over to you, Shepard, and I suggest we discuss them one by one and invite questions after each one. And we go through it in that way. Is that okay, Shepard?
I was just going to suggest that I cover all of them as
Okay.
Yeah, mainly because things have progressed. You would note that these inspections were done way back, some of them in March and stuff, and a great deal of work has taken place. So this is kind of a formal kind of position noting for this meeting.
Yeah, that's fine. Over to you, Shepard.
Just to confirm that we've got 3 formal reports that have been published now. For the 3 practices, that is Beecham, Orchard, and Manor Farm Medical Center. And all the 3 practices have been rated as inadequate on the overall. There are key themes there around all of them. Caring has been good. There are issues, I think, mainly on the well-led domain, responsiveness in areas. But what I'm really pleased is that a great deal of work has gone into supporting these services to turn around. And there are no immediate concerns or any concerns I need to raise with the committee today. All practices have got an action plan in place, and the action plan is being monitored on a regular basis with CQC, with the locality CCG colleagues, with the practice, and good progress is being made across all the practices. I will stop there and ask if there are any questions or queries from the members.
Thanks, Shepard. Opening it up for questions and comments from anyone on the 3 CQC reports that were in the pack. Vivian and then Chris.
Thank you, Chair. Yes, I just wondered, and discussions with Andrew, we agreed on this question together. How is the learning shared about the causes of the problems and then the resolution of the problems and the ongoing plan? And how is the comms to the public and wider patient groups around those practices communicated? Because I was just picturing residents who would be extremely anxious and wanting to know how they can trust their GP surgery if this has happened, because a lot of people won't understand the process. Thank you.
Thank you. I'm mindful Chris is also on the line and also he's raised his hand, and we work quite closely in supporting practices. I'll be probably, if we can go to Chris, then if I need to add anything, then I will do.
Okay, Chris. You're on mute, Chris, sorry. I can't hear you.
Certainly better.
Yes, thank you.
Just to say, I would just concur with what Shepard had said. So our teams both work very closely together, and just in terms of the update that you've given, I think progress has been made. I think just in response to Vivian's question, I think we can't underestimate some of the challenges of the pandemic and the pressures that primary care is under. And I think that's why we've now tried to move to a mixed programme or a blended option of support. So not only do we provide the reactive support when practices have been inspected and if their inspection hasn't gone well, but also we've tried to take a more proactive approach to providing regular training on a monthly basis on some of those key areas that we're finding within the CQC report. So I think it's fair to say we've got a more blended proactive model moving forwards. I don't know what your thoughts on that are, Shepard.
Absolutely, Chris. I think our sessions to support practices to learn from some of the turnaround work seems to be working very well. And it's focusing on leadership, it's focusing on organizational culture, it's focusing on long-term conditions and staff and well-being. So it's really good that CQC actually are leading for us in those sessions on the leadership for practices. So we've identified the strength that sits within our system in terms of providing those sessions, so the quality team leading on quality aspects of it. So I'm really positive about this gradual development of our system in terms of learning, but I think there's more we need to continue to learn every day as we go through the process.
Thanks, Chris. Thanks, Shepard. Hilary?
Hi, thanks. There's a question really, and then a comment. The learning meetings that you've arranged, how much attendance do you get from practices? Do you know what the numbers are like? So that's the first question. And then after the last meeting that we had, I mentioned it to some practice manager colleagues and they weren't aware. And then they did some digging around and found that it was kind of in one of the newsletters that comes out. So it hadn't been really apparent. I just wonder if it's worth communicating to practices about this because it's so important separately with a heading saying CQC, which would definitely get their attention just so that they know about these meetings and you get the best attendance.
Thanks, Hilary. Yeah, I think so. Certainly the attendance. I think we've got a session next week, which is the third session since we've relaunched it. So we've tried to keep a set day and time so that it becomes a regular known thing and embeds. I think we've had. I think it started off around about 30. I think the second session there was about 40, and there's 40 plus. I think. Acceptances for this session next week. It does go out in the GP newsletter, so we do try and advertise it in there. I guess we can probably look at whether we can ask the LMC to support as part of their newsletter as well, just so that we're using every sort of communication channel we can. So happy to take that forward, Hilary.
Thanks, Chris. Any other question? No, thanks very much, Shepard and Chris. I see Anne has joined us, so we'll move back to item 10 on page 47 or 45 of the pack. And thanks for preparing this. Over to you to pick out the highlights, and then we'll open up questions and comments. From you to Anne, sorry.
Thank you very much. Hello, everybody, and thanks for having me along today. So the only question I had in advance was around the cyber incident that's currently been experienced by Advanced Health and Care. Advanced Health and Care products, Adastra, CareSys, Odyssey, Care Notes, CrossCare and Staff Plan are all affected by a cybersecurity incident caused by ransomware on their infrastructure. None of those products are in use in this area. Adastra is a prominent system in the 111 and out of hours market. Is very widely used across the country, but not in this area. And Care Notes again is widely used in mental health systems, but not in this area. We do have two products in the area that are made by Advanced. One of them is DocMan. However, Advanced acquired DocMan a couple of years ago and haven't assimilated them. So they still, the two companies effectively are run very separately, and the infrastructure is completely separate. There's also an online consultation system provided by Advanced called Patches, and that is in our portfolio. No practices are live with it, although a couple are trialing it at the moment. Not live with patients, just in the background. And again, we are assured that it lives on completely different infrastructure from their main health and care systems. the National Cybersecurity team are leading the response to this. They're working with Advance very closely, and obviously those organisations that are affected are suffering major issues because of the lack of access to systems. So we will obviously keep up to date with that in light of the fact that we do have some systems by Advanced in the area.
Thanks. And people have had a chance to go through the notes. So does anybody have a question or comment for Anne? One point I made outside the meeting already to Sadie, and is once the shared care record has been operating for a few months, it would be good to hear how it's working in practice, maybe a combination from an IT perspective and then a healthcare professional. Are they seeing already some of the early benefits coming through? So you're better placed to advise on suitable timing, whether it's early in next year or so, but it's great it's coming soon.
Yes, it is. Yeah, project's going really well, but a minor technical hitch that's caused a couple of weeks delay with the central integration engine, but that's been resolved now, so things are moving along again.
Thanks. Any questions or comments? No, many thanks, and for the update and for providing us the update on what happened on the 111 system nationally.
Thank you very much.
We move to item 12, the prescribing report on page 65, I think, of the pack. 64. Michael, over to you, and maybe you can weave in the two action items that were on the action overview. Thanks.
Fine. I'll take the paper as read. This is my usual report. I've added one or two extra things this time. Always happy to have feedback on anything you'd like a special item to be added to the next report or something on an ongoing basis. So if you wanted a monthly update on something, do send in some feedback. So just thought I'd highlight the fact that the CSU has now merged with the CCG team, and we're now the ICB team, and we're working on new governance arrangements in terms of meetings, etc., and sign off of papers. We are carrying quite a few vacancies. I thought I'd just list those just so you've got sight of those. On section 2, the usual bar chart of where we sit regionally in terms of raw cost per patient unit, and we're in our usual place of 5th highest. We are getting closer to the 6th position, which means we're moving towards slightly more cost effective, but on the whole, as I've said previously, those bars go in terms of deprivation of the total population. So spend is partly and mostly driven by population and by deprivation indicators for a number of reasons. Category M changes an NCSO. So table 1 just shows you that NCSO, there is a trend of upwards movement in terms of price concessions due to shortages. So that's something out of our control. But just so you have sight of that, and we'll keep monitoring that each month. So that could affect our outturn. In terms of, we've only got 2 months worth of data, April and May so far. And the tool we use at the moment is predicting a minus 1.4% against budget outturn, but that comes with lots of health warnings because it's only 2 months worth of data out of 12 months. And there's some big rebates to come back in, which will certainly help with that. Table 2 is just highlighting there is a big increase in spend on one particular cardiovascular diabetes medicine. SGLT2 inhibitors is taking off significantly, and that will only continue to rise. Okay, so that's spend. So quality indicators, dependence forming medicines. We're continuing to work on this. Some of these is in the prescribing quality scheme. High dose opiates. So just a reminder, first position nationally would be worst, which you know, so not the best. It'll be the worst position. So there's 106 organisations, and at the moment high dose opiates we're 76. So that's down the list in terms of volume, which is where we want to be. We don't want to be using high quantities of high dose opiates. Gabapentinoids, we're at the 74th percentile, and we've remained 28th position nationally. Hypnotics and anxiolytics, which is in the prescribing quality scheme, still third nationally, but we are coming down. And at some point in the future, I won't commit to when, we will be off the third position nationally, because the trend is definitely accelerating compared to the average of national, which table 4 shows consistently. Antibiotics, still not exactly where we want to be in terms of antibiotics. We are engaging with a fair few practices on this. So if you look at table 5, this scatter plot here, it shows West has the highest volume and probably equal highest equal highest volume to Norwich, but has the highest percentage of broad spectrum antibiotics, which are the ones we want to avoid using too much for various reasons, resistance, etc., and increased risk of C. diff. And you can see GYW has the lowest percentage of broad spectrum antibiotics. On the next table 6, we break that down into different PCNs. So you can see, you know, some of the West PCNs are reflected there. There's a bit more detail in terms of where we are, and we've listed our higher outlier practices in terms of broad spectrum antibiotics, and most of those we are currently working with and have done some work and have made some improvements going forward. Prescribing quality scheme, there was an ask reference to EMIS and Optimize RX. Part of the prescribing quality scheme was that practices enable Optimize RX, which we've paid for all practices, which has mostly clinical safety and quality algorithms in it, so it'll pop up with reminders tailored towards that patient in terms of monitoring, not up to date, etc., or looking for read codes, which means certain drugs are contraindicated. So it's beneficial in terms of those aspects of drug safety, etc., and drug monitoring, and will help you with MHRA alerts, which the CQC are quite hot on. So in terms of how many, for instance, how many EMIS practices use Optimize RX? We've got 13 at the moment. It was 14, but UEA have just changed to System 1. And we've only got 7 practices not using Optimize RX at the moment. And of those, 5 are EMIS, although 2 are in the process of changing to System 1, and 2 are currently System 1. And there's no known issues with EMIS and Optimize RX, although EMIS do have a reputation for breaking bolt-on software when they do an update. That used to happen regularly with ScriptSwitch. Low-risk, cost-effective prescribing, Cqc support scheme. We've sent all the papers to the LMC, somewhat too late, I apologise for. In all the excitement of getting it approved, we were so keen to roll it out that we didn't do the appropriate engagement with the LMC. So we have made arrangements to meet on a regular basis and discuss any schemes in preparation, so that we avoid those issues going forward. It is essentially a version of a scheme we did 3 years ago, which was reasonably successful until COVID appeared in March 2020. Yeah, and that was all I was going to cover. I'm happy to take questions, comments on any issues.
Thanks, Michael. Any questions or comments for Michael? Vivian?
Thank you, Hein. Yes, I guess it's my mantra for this meeting, how the patients are involved in understanding their medication and the interactions, as well as what is necessary and what things cost. because I'm just very aware in my own area that people are absolutely unaware, and there might be a letter that arrives explaining that these two drugs are particularly unhelpful in the long term, but most people, as far as I can tell, put those straight in the bin. And I wondered what work might be done with partner organisations, because I know how stretched all the practices are, and having a conversation with patients is time consuming. But it just struck me in the long term, if there was a plan to reach all the patients personally who had these difficulties, whether you might get a more cost-effective outcome. I just think there's enormous waste, and having been in the community and seen people's cupboards, they just reorder everything, and I see a GP colleague nodding, and they don't understand the difference between what drug does what is important and what isn't. But I don't know who and how you facilitate this. So I'm raising a question which might be a wish list, but I just wanted to park it so that perhaps it will get some consideration. Thank you.
Okay, Michael, you want to go?
Yes, I'll have a go. Yeah, I mean, reducing waste is something that we work on constantly. It's really difficult without micromanaging every interaction and every order of a patient. It would be impossible to really address it and talk to patients about what medicines they've got in stock before they order. We do have a system in one part of the area called POD, Prescription Ordering Direct, which seeks to do that in terms of patients phone in, which may be seen as old-fashioned way of doing things, but it is actually quite useful to talk to patients about their medicines and check what they've got in stock before supplying what they need and want, and not supplying things that they don't want and don't need, which some inefficient systems do create, which I could go into at great depth, but I won't today. So I'm well aware of some of the things that cause patients to get things they don't need, and perhaps are confused about some medicines. The practice PCN pharmacists, clinical pharmacists in GP practices, are part of the solution to that. So they with our keen encouragement, look at complicated patients with lots of medicines who are likely to need more help and likely to have more problems with their medicines, and they target, I mean, with the best will in the world, I'm trying to think of a better word, focus on, okay, there's a better phrase, patients who are more likely to need help, and do what's called structured medication reviews. So they talk to patients about their medicines in some detail and get people stopping medicines that they no longer need or choose not to take, because some patients, there's plenty of research that after 6 months, some long-term medicines, patients just choose to stop because they don't really understand why they're on them, and perhaps they make them feel worse in some cases, and they don't understand the benefits of perhaps continuing to take them. So it's a very thorny issue. We're well aware of what we could be doing, but without having the micromanaging every transaction, that's the difficult one. Always happy to talk to patient groups. So before COVID, I was a regular attender at patient participation groups and various other fora to listen to patients' issues and etc. We are working on rolling out our pod to practices who are willing to take it on, and that is one way of focusing on reducing waste. We've also got there's a national review of repeat medication ordering systems, and I've already tasked, when that does get published, a member of my team to offer audits to practices so that we can streamline and have a reasonably standard process, and just, with the best from the world, just smooth out any issues within each practice in a tailored way, because that is sometimes a cause where things go awry if the systems aren't working perfectly all the time, etc. So that we do plan to do a review when that national document is published on streamlining systems, but also rolling out, as I say, our pod to practices. So hopefully that answers some of those issues. But it is medicines waste is really difficult one to address, but we've got things in place which certainly can help.
Thank you.
Thanks, Michael. There's no further questions. Many thanks for the update and addressing the points in the action log, Michael. So for the minutes, Sarah, we can close those 2 actions. I see Mark has joined, but Mark, I'm going to go to James Granger first and then come back to your point. So James, over to your finance report from page 83 of the pack. Can you take us through the highlights?
Yeah, thank you very much. Yeah, so as usual, I'll take the report as read, but highlight the key points in the report to you. So firstly, on the exec summary page, I just need to point out the report is produced in arrears due to the timing of the CCG and now ICB month ends. So it's reporting the final month 3 accounts for the legacy CCG. So as we can see from the exec summary, the final position at month 3 for primary care and prescribing budgets are 2.88 million favourable to budget for Q1. This position includes an efficiency target of just over £1 million built into that budget, and this forms part of the full year efficiency requirement of £8.4 million. As we can be seen, these efficiencies are not phased in a linear fashion and do build up over the year. Moving on to the financial summary, it shows that GP prescribing itself is 1.1 million favourable to budget as at month 3, with the figures being 2 months in arrears. That represents an overvaluation of the April and May 22 estimates. In addition to that, efficiency savings have materialised in the period, allowing the forecast to be delivered, and in some schemes specifically over-delivered. These efficiency expectations are already baked into this budget. Of the £1 million requirement for the quarter, we've received 1 month of actual achievement, and this over-delivered. However, this does need to be given with the health check. I think, as Michael said earlier, given the lack of data at month 3, this could change as we go further into the financial year. There are also some prior year benefits within GP prescribing as well, contributing towards that favourable budget. The other large variance, that there's a prior year benefit within delegated primary care, which is crystallised of £1.8 million, which I will cover later in the update. Moving on to the detailed finance analysis, this shows the key drivers behind the prescribing underspend of 1.1 million against budget, and describes some of the key areas of risk around CGM, SGLT2, and where there is a high degree of uncertainty over the financial implications of these factors. Due to this uncertainty, we've provided for both of these at month 3. Moving into the specific funding areas, the System Development Fund, this key area of investment is showing as overspent due to the PCT transformation costs and ambiguity over this funding. We as an organisation are committed to spend GPIT staff costs and an historic commitment to transformation spend. So both of these areas have been provided, which are creating this overspend. Moving into delegated co-commissioning, positive variance here is mainly due to the prior year crystallisation of benefits due to slippage within QOF from 21-22. And then finally into GP and other prescribing, this page shows the detailed variances with prescribing leading to that £1.1 million underspend. The differences stem from prior year benefits flowing into GP prescribing. Some of these benefits have been absorbed by the risks around continuous glucose monitoring, SGLT2, and NCSO and DOACs, realising a £0.6 million benefit after this absorption. Other benefits come from historic vacancies within the legacy CSU Meds Management team, which have been repaid from the original SLA. So that was all the areas I wanted to highlight. Are there any questions?
Thanks, James. And I know you and I had benefit of an exchange before the meeting. What struck me is not just a favourable balance at month 3, but there's quite a few cost pressures lurking underneath.
Certainly is, yeah.
To those, so we'll learn more in the months ahead on how that's materialising. Are there any questions for James Granger? No. Many thanks for the update, James. We circle back to item 6. Thanks for joining, Mark. Can I hand over to you to guide us through your note?
Thank you, Hein, and apologies I'm late. I was actually with primary care colleagues in Great Yarmouth and Waveney, actually talking through some of the really good things that are happening there. So time well spent, but apologies I'm late for this meeting. So the report I will take as read, but there are just probably 2 or 3 things I would like to kind of focus on as part of the report. Firstly, I think it's important to note here that the system is under really intense pressure from an urgent and emergency care perspective at the moment. I think everyone is aware of that. And the report does highlight some of the things that are happening, but I would just like to emphasise, and I'm also trying to take this line with colleagues in the system, that when we talk of urgent emergency care, people tend to think of ambulances and hospitals and things of that nature. But I do often remind people that 80% of urgent care is still dealt with in primary care. So I think it's, I know I don't need to tell people here that, but I think that's a really important note, and that's certainly the messaging that we're sharing with colleagues. Linked to that, the report talks about the 100-day challenge and many things that are happening around the urgent emergency care agenda, but we are expecting funding from region this year to support us over winter. It seems bizarre to say this in the middle of August when we've got another heat wave, but actually we're seeing those very real pressures that we would typically see in wintertime now. So many of those things, and we look to be working with primary care colleagues and general practice colleagues to really think what can we do to make ourselves more resilient, because we know that there are very real resilience challenges in general practice as well. More positively, we've had our first round of place boards during July and early part of August. Had unanimously very positive feedback from those boards, and I think there is a real appetite with general practice primary care working with system colleagues, be that district councils, community health colleagues, mental health colleagues, around what can we do at a place level. So we want a strong Norfolk and Waveney system, but there is really scope to work in neighbourhood, to work at place, to support many areas. And actually, referring back to my previous point, there were some really innovative ideas that were coming forward from general practice and colleagues about what can be done at place level to support us over the winter period. So I think there's a real appetite to make sure we progress that, and importantly progress some of that at place. But I would be quite keen in future meetings, perhaps in a few months' time, to bring forward to this group some of the work that is happening at a place level. I think that it would be good to get your views on that, input to that, and also for your awareness. So I will do that. And the final point, it is great that we have a new medical director now, Dr. Frankie Swords, has joined us. The report talks about the work that Frankie intends to do to support primary care and general practice, and already held the first engagement session with the clinical directors, not in the report, but also she has been shadowing in primary care and intends to do a bit more of that. I think she's spent the day in a couple of practices, which I know she has found really enlightening. Just to see some of those pressures and see some of the work that's happening, given that Frankie's background is more from an acute background. So just to state really that Frankie is very keen to support the work here that this group does, but also general practice more generally, working with Hilary and others as well. So I'll pause there, and if there are any questions, more than happy to take them. Thanks, Simon.
Thanks, Mark. Any questions or comments for Mark? No? Oh, Vivian, please go ahead.
Sorry, thank you. Yes, I there's no mention of King's Lynn, and I know that that's probably not your remit, but clearly the knock-on for the people in West Norfolk who can't have surgery, where the backup for the surgeries in that area must be awful. I just wondered what the plans were to ease the pressures in West Norfolk, and whether other trusts are getting involved, or how that whole situation is being dealt with. Obviously this is about patients and communications and communities, which is very much Health Watch's remit. And I would like us to welcome the new medical director if we get the chance. So if you had mentioned Health Watch to her, and I'm sure that the chief exec would love to arrange for her to come to one of our meetings and also to hear about our work. So that would be really, really good. And I'm just a little bit surprised to see that when it's to do with patients, the NHS constitution was non-applicable, because I thought the whole point of the constitution was about the patients. So that just surprised me a bit. But yes, I look forward to your answer. Thank you.
I would agree on the last point, Vivian. And when you say about the West Norfolk element, it absolutely is a part of that. Could I just check, Vivian, were you talking about the elective care in particular, those waiting for elective treatments?
Yes, I was primarily, but also obviously there's a knock-on with all the services there. If every ward and corridor doesn't know if each day it's safe, it must have an effect on every department, I would think.
Yeah, you're absolutely right, and I think what can I say? It's really important that we work together as a system, and I absolutely recognise that is happening. So, for example, given the intense pressure on the system, we have a number of gold calls where we have community colleagues, acute colleagues, and we're not looking at it just as a Norfolk and Norwich or Queen Elizabeth or a James Paget. There is good working between the two. There's more that we can do, but we will survive this winter, if we take that as an example, and recover the elective position by all working together. I know that sounds really positive and simple and easy to do, but actually I genuinely believe that's the only way that we will do that, about spotting the opportunities and actually some of those ground up ideas and things that we could do differently to best support patients, particularly those who are still waiting for treatment, particularly long times. It's good to see that those treatment times are coming down in the main, especially the very long waits, but we've still got an awfully long way to go there. And actually there are conversations ongoing with general practice colleagues around how can general practice work with acute colleagues to look at what can be done. So yeah, absolutely, it's not in isolation.
And if I could just follow that up, obviously this morning in the news there was discussion about the elective waiting list has been greatly reduced, and I wondered if we had any comparative figures for Norfolk and Waveney as to how our electives are and what our waiting list situation is. I was hoping we might have some numbers in here, in fact.
We absolutely do. They're monitored very, very, very closely, as you won't be surprised to hear, Vivian. Not just us locally, which we would do anyway, but also regionally and nationally. So we're more than happy to share some of that information at a future meeting, if that would be helpful. Perhaps I could include that in my next report, just to make sure it's covered.
Thank you.
Thanks. Any other questions or comments for Mark? No, many thanks, Mark. I think an update in a few months' time on what's happening in place boards and the good ideas that are coming out of that would be, I think, very helpful for the committee to see. So good. And that takes us to 14 questions from the public. Can I check, Sarah, did we receive any questions through email or other means?
I'm aware of mine.
Good. I'm aware we have at least one member of the public on the call. So is there any question from the public, from those on the call? I think there's a no. Then any other business from anyone? Vivian, I'm not sure if it's a legacy hand or a new hand. Let me just check. Good. If there is no any other business, I want to thank you very much for your attendance on part 1. For those attending part 2, I suggest we reconnect at 5 minutes past 3. There's a separate link in your meeting invites or in your email list. So look forward to seeing you then. For everyone else, thanks for joining. Have a good rest of your day. Thank you.
Thank you.
Thanks.